This week, we'll be discussing the hospital industry. Over the years, the hospital industry has changed dramatically. Hospitals were coming around in the early part of the 1700s, 1600s, but with advanced medicine, like the launch of penicillin, and also advanced technology, like the invention of the X-ray, the way the hospitals used to be in the old days changed dramatically. Uh, and starting in the 1900s, many hospitals had to figure out how to pay for their existence, and they started to partner with religious institutions. And that's why many of our hospitals today tend to have a religious overtone. Think of New York Presbyterian Hospital, for example, Mount Sinai, for example, and a lot of Catholic churches partnered with hospitals, St. Jude's, for example. And so that's where that connection came from. They were looking for ways to pay for those services. Um, Another thing that happened, this is before insurance started, another thing that happened was hospitals were not necessarily being put into places where there were large populations of low income folks. And so this was a market failure that the government looked to rectify. And the Congress passed in 1946 the Hill-Burton Act, and the intention of that was to increase the number of hospitals in the U.S., specifically in places where there was low-income folks, and specifically so that they could provide free and low-cost care to folks that were not of means. And so once Congress gave money, it changed the system. And so the key here is the Hill-Burton Act changed the dynamics around the barriers of entry. There's obviously a lot of barriers of entry to become a hospital. You have to buy real estate, you have to buy property. It's very expensive. There's a lot of fixed costs, so it's very expensive to run. But by Congress providing that money, it led supply to come in. So this is an example of government changing through subsidies how the supply side of healthcare works. And so more hospitals, and obviously the hospitals had beds, so more beds. So what do you think that did for supply? So with more beds, more people had the opportunity to see the doctor. However, technology lowered the time that people had to stay in the hospital. So length of stay dropped dramatically. You can see here, people were staying in the hospital shorter, so short that they could leave the same day. And so you can see the increase of outpatient visits from 1965 all the way up to 2007. It was a dramatic increase. And then the other flip side is people who were staying in the hospital. Think about 9 days in the hospital in 1946. Could you imagine at your hospital, the average of someone staying at the hospital was 9 days, which now you see through 2002, it's even lower down to 6. And I would argue as of 2018, it's down to 2, if not 3 days. So we increased outpatient visits, we decreased length of stay. Majority of it has been done through technology advances. People recovered better technology, better medicine. And then also insurers changed the way they paid hospitals. We talked about in your last case study, the RAND study, the PPS methodology of payment, prepaid payment. And what that did was it provided DRG rates or even case rates. It divided a rate for a service. And so hospitals had to figure out how to take care of that patient for that rate. And if they spent too much money, if their expenses were higher than the revenue, they would lose money. So they changed the way they rendered care in order to make money on the DRG rate. And so that's what the PPS system did. So in a second bullet, you see there, insurers increasingly designed hospital payments to incentivize shorter hospital stays. They would pay the hospital for a sick patient and say, I'm only paying for 5 days. So if they were able to get that patient healthy and out the door in 4 days, and they did it with less revenue, less expenses than the revenue they received, they were able to keep the balance. Another key piece is how different hospitals work and their relationship to the physician. So it's very important to think about the contracts that physicians have with the hospital and what that does to care. And so, from an economic standpoint, we look at what's the economic incentive for the staff based on how their arrangement is with the hospital. And there's a couple of modes. You have the first one called the physician's workbench. The majority of the US uses this. And this is where the physicians are not directly employed by the hospital, but they work in the hospital. And one would argue, and you'll see it in the reading, that since they're not tied to the hospital, as insurance companies change the payment models and make them more around DRGs, the doctors that are not employed don't have skin in the game, meaning they don't have a financial incentive to be efficient. So they're there to see patients, they render care, and they bill the insurance companies themselves. And they also are not worried about the collective unit, the collective hospital. They're really worried about themselves. They think very individually. So the physician workbench has its pros and cons. The pro is that the doctors like this model. They don't feel restricted. They don't feel that they have to follow many rules and guidelines, and they're free to do the type of healthcare they want with a lot more parameters. However, the negative is the hospital really doesn't have a control over or methodology for managing all of these different doctors. An example would be comparative effectiveness. If the hospital like to institute a specific way to take care of a patient for a certain procedure, it would be very hard to do so with a physician's workbench because those doctors are coming in, they're coming out, and it's very hard to tell that doctor what to do. Those are the pros and cons. And so the theory is, we talked about physician-induced demand last week. If you have those type of physicians inside your hospital, the theory is costs won't go down because the doctors are still acting independently, which is why in developed nations that have universal health care, like the UK and like Canada, many of the physicians inside the hospital are direct employees. Kaiser has this model. Kaiser, the hospital, owns the employees. The doctors are employees of the hospital, and they call those hospitalists. And this changes dramatically how doctors operate. Now, this doctor has a salary because they're an employee. They're not earning per surgery, so their incentive changes. If they do 10 surgeries or 8 surgeries, they get the same amount of money as a hospitalist. So now they're not thinking about getting through surgeries faster for purposes of submitting claims for revenue, where a physician workbench would be thinking about how many patients can I see in one day because each patient is revenue to me. The other piece is it's much easier for hospitals to control how the doctors render care because they're hired employees. So they can be fired and they can be reprimanded and they can be let go and they can track how these doctors operate and they can track the costs and the expenses and everything and tell them what to do. So it's a much more command and control approach that they've seen. And this cannot be understated. This is directly correlated to universal healthcare. So when you have a single payer system, it always talks about getting rid of the insurance companies. They only have one person pay insurance, but people rarely talk about this aspect of it, where a direct employee model is also in place in many of these countries, where the doctors work for the hospital. So you have to kind of combine the two if you want to get to the same type of low cost that a universal healthcare system has. And then lastly, you have physician-owned hospitals. And what this was is a collection of physicians that got together to own a hospital. It's kind of a hybrid between the two. And here what they're trying to say is it's okay for physicians to be employees of a hospital if, in fact, the hospital is run by physicians, because the physicians will know how the doctors feel. Very interesting enough, sometimes you see once a physician becomes in administration, they change the way they act and the things that they think about. But it is another type of mode for a hospital to have a relationship with a physician. So you have to think about the trade-offs. Are the physicians loyal to the hospital or to the patient? If they work for the hospital, they're probably loyal to the hospital, meaning they would do what the hospital tells them to do because that's who pays their paycheck. Where the physician is who is in the physician's workbench model, where they're not employed by the hospital, if they are told that they can't do something, they might then get admitting rights to another hospital and leave. And they're going to do what is best for the physician. I'll leave it up to you to debate that. Uh, and we talked about the latter piece of where if you're not connected to the hospital, you're not really connected to the mission. And you can see direct examples between how Kaiser operates with their hospitals versus insurance companies that don't have a hospital, like an Empire Blue Cross Blue Shield or a United Healthcare. So there is in your text a concept that is called the positive value outcome correlation. And what it argues is if people see the same thing and do the same thing over and over, they begin to specialize it. This was actually thought of way back when in the 1700s under Adam Smith in his book Wealth of Nations, where he talked about labor, and labor with specialization in the factory can enable workers to become better at very specific tasks. So rather than having them do everything, they would only do a certain thing. And that's kind of the birth of the assembly line. Like, don't fix the whole car. All I need you to do is this one thing. And you do this one thing and you specialize at it. And you become extremely versed in that one specific thing along the assembly line rather than doing everything. The same thing holds true in healthcare, where we actually have data to show that surgical mortality rates decrease as the hospital increases its volume. So on this chart, you can see hospitals that have the highest 20% of volume have the lowest mortality rates. The coronary artery bypass grafting, if the hospital had the lowest 20% of hospital volume, you could see the mortality rates at 6.1 compared to if they had the highest, it was 4.8. And what does that tell us from an economic perspective? Suppliers do better and get better when they supply the same thing, specialization. And so from a healthcare economist perspective, what we would want to do is think about a term that's used popularly today, centers of excellence. So rather than having a hospital do every procedure, figure out across a neighborhood, across a zip code, across a state, centers of excellence where hospitals specialize in certain things. One hospital specializes in cancer, for example, like Memorial Sloan Kettering, or one hospital specializes in joints, similar to hospital chest surgery. And by the specialization, you get really good at your craft, and then costs go lower because you have less errors and you improve your process. You're looking for process improvement. And that's another hypothesis where you talk about learning by doing. The high volume leads to good outcomes. So think of a hospital in a rural area that sees every single procedure but only sees it one or two times. That tends to be wrought with issues because they don't see the same issues over and over and get to learn. The other piece of it is, and similar to hospitals that advertise what they're good at, you start to see a selective referral hypothesis where the good outcomes then lead to higher volumes. And this is obviously seen in things like Cedars-Sinai Hospital that's well known for a certain procedure, or seen in other hospitals that specialize in procedures. They tend to, again, get a very good brand name for themselves, and then that brings the higher volume to them. It's sort of like they get selected based on their attributes of what they're known for. So based on that principle, you then have to ask yourself, does the hospital experience matter or does the physician experience matter? Which one matters more? Some might say that you should prefer to go see the best physician, while others might say that you should go to the hospital that has the safest results and quality outcomes, regardless of the physician. Human brain, human nature, logic, common sense might say, nope, I want to go to the physician. The physician who has the best results or who's well-renowned is probably the safest. However, as all of you know, as clinicians, healthcare is bigger than just a physician. So in actuality, there's enough evidence that says actually hospitals with more surgical experience have fewer complications. We know that. But it also shows that when there's team settings And after a surgery, you sit down with all the doctors and the nurses and the staff and go through what could have went better. You could then less rely on the actual physician and more rely on the hospital. And so a hospital high quality ends up having better outcomes than just a particular physician that's really world renowned and good at their craft. So this again, the individual physician becomes less impactful. Why is this important? A way to get around monopoly rents. Hopefully, you all remember what monopoly rents were in last class. A way to get around it is through teams of medical workers that collaborate on surgeries. Because the monopoly rent theory states that you have to overpay for physicians because of the barrier of entry for physicians to enter the workforce. That overpayment then translates into higher healthcare costs. However, if I can mitigate that overpayment by saying I don't actually need the best absolute physician in their field, if I can learn from a high, above average quality physician and teach other physicians and nurses and the staff lessons learned from other surgeries, I can actually have better quality from a hospital standpoint, which has better outcomes than just having the very experienced single physician. Now we're going to talk about the relationship between hospitals and hospitals. So hospitals, what we like to call them, because of their barrier entry and because of how few there are versus other physicians, are differentiated product oligopolies. People call it oligopoly, people call it oligopoly, but what it means is it's not a monopoly, mono meaning one, it's an oligopoly meaning few. It means that there's very few suppliers. Now, in class, we talked about the more that there's competition, the price goes down. So obviously when there's monopolies, prices are higher than they should be because there's only one competitor. Oligopolies mean there's a few competitors. So while the price might not be as high for an oligopoly as for a monopoly, they're still higher than in a regular market where there's lots of competition. Now we add the extra wording, differentiated and product. And that means that even though there are few of them, they all sometimes specialize in certain things. And so that means you can have a few hospitals in Long Island, but the hospitals in Long Island specialize in different things. They can all deliver a baby, but they do have a specialization. So what it means is it's kind of a blend between a true oligopoly and a monopoly, because even though there's a few firms, there might be only one hospital in Long Island, for example, that does a particular procedure really well, and they specialize in. And so what that ends up saying is our supply side on the hospital side is very, very small. It's very reduced. And when you have a very small supply side, that makes demand go up. And when demand goes up, price goes up. And there's a strict barrier to entry for hospitals. It's very expensive to become a hospital. The buildings are price prohibitive. The technology you need across the whole hospital's price is price prohibitive. The staff, extremely expensive. The number one expense for a hospital, and I put up the Northwell 990 on our Canvas website on this week's discussion. The expenses are number one. Staff is the number one expense for a hospital. That's where it starts, paying for the doctors, the nurses, and all the other staff. And you can look at the 990. A 990 basically is like what a nonprofit files to show their revenue expenses. And as a nonprofit, they have to show the salaries of their top 10 income individuals. So you will see people's incomes shared in the 990. And it just goes to show you can see where their expenses go and you can see where their revenue comes from. And in the administration. So the key thing for a differentiated product oligopoly is one, an oligopoly means few firms that are in the market, a few. And even though that there are few, they specialize in different things. You might have a children's hospital versus a cancer hospital. So there might be a few, but then it still feels like one. It still feels like a monopoly, right? And then there's barriers to entry because of how expensive it is to become a hospital in the first place. It's very cost prohibitive to buy a big building and to buy land, et cetera, et cetera. Services provided by each firm are not perfect substitutes. So remember we talked about in the demand side that there's substitutes for goods and there's complements for goods. In the hospital sector, there's not true perfect substitutes. So just because you have more hospitals in a city than another city doesn't make it more competitive because those hospitals are not perfect substitutes. So even though you might have 5 hospitals in a certain area, it doesn't mean you have 5 teaching academic medical centers. They all could be different types of hospitals. And that differentiation deteriorates the ability for there to be lots of competition. Now, how do we measure which areas have strength versus don't have strength in terms of hospital leverage? How we do that is an index called the Herfindahl-Hirschman Index. And the Herfindahl-Hirschman Index is used to figure out how strong the hospitals are. If the hospitals are closer to 1, it means that there's few firms in the market. And the fewer the firms, it means that the firms have more power because you can't have that hospital out of network. For example, for an insurance company, the hospital has to be a network. And it also means that they're more likely to get ambulance to see their hospital because there's not that many other hospitals to go. Many rural areas tend to have very concentrated high HHI indexes, right? Herfindahl-Hirschman Index. Now, if the HHI is closer to 0, it means there's a large number of firms in the market, and that means that their power is less because when there's lots of competition, then demand can go to different places. So demand is lower, so prices come down. When there's little competition, the demand can only go to a few places, so the prices go up because the demand increases trying to just go to those few places. So how do we measure the level of concentration of hospitals that are in this differentiated product oligopoly? Is through the Herfindahl-Hirschman Index. Now, it's not just the fact that there's limited competition that causes hospitals to raise their prices. And we're speaking this about these hospitals in the context of the supply side. We talked about the physician side last week, and now we're talking about the hospital side. There's other reasons that are due to barrier of entry. One is prices are not transparent. Now, we talked about this. Medicare, Medicaid all have a fee schedule for different procedures. In the private insurance world, where half of the country gets their insurance from, those prices are very confidential because the prices differ by insurance company. Empire Blue Cross Blue Shield's negotiated price is different than United Healthcare's negotiated price. So the health plans don't want their information shared, and the hospital also doesn't want their information shared. They don't want Northwell doesn't want NYU to know the price points that they have with Empire because it might be lower or it might be higher, and so they keep it. What does that mean for the member? It means that the member doesn't know the price point that they get. And when the member doesn't know what the price point they're going to get, that means they're probably going to pay more money than they should for insurance. So the lack of price transparency makes costs go up. We're going to talk about moral hazard later on in the class, so I won't address it now. But moral hazard just means if I have insurance, I tend to do riskier behavior. It's like if you have your seatbelt on and there's no one on the road and you have great car insurance, you probably might feel more comfortable speeding than if you didn't have your seatbelt on. There's a lot of people on the road and you didn't have good car insurance. So the more safe you feel, the more extra or the more advantageous you might be. And that moral hazard also increases costs. So insurance causes a barrier to entry because it hides the transparency of the price, and it also causes moral hazard. People act differently when they have insurance than if they were uninsured. We talked about how the government sets its price. Now, that can be good and bad. Now, we talked about that the private insurers tend to pay more than the government payers, Medicare and Medicaid. So if a hospital tends to get more Medicare and Medicaid members and patients, then they're getting less money per person than they are from the counterparts that have more commercial or private insurance people. And that can change how they render costs. If I'm getting too many Medicaid, too many Medicare members, then when I negotiate with my commercial folks to try to get private insurance, I might negotiate those rates higher to offset the losses I'm making on the negative one. And then, as always, emergency nature of healthcare means that patients are unable to search for the best and cheapest hospital. We talked about this. You're not a savvy consumer when you're sick, and you're also not a savvy consumer when you have to make a decision very quickly. And all these things lead to more expensive costs. And all of these bullet points give power to the supply side, the hospitals, to raise their costs on consumers. Consumers don't have any power in this dynamic. Now, we want to know, well, there's not a lot of competition in hospitals, but if there was, would that be good for patients? And they say, typically competition improves quality and lower prices. And we talked about that with flat screen TVs. We talked about that with cell phones, but healthcare is different because, again, insurance, and this is so key for health economics. As much as people need health insurance hides the price of the service. So it actually hinders the ability for consumers to really shop and know the true cost of healthcare. And then the other piece is physicians have the physician-agent relationship, which we talked about last week. So they tend to listen to where their doctors tell them to go. And our doctors referring physician and patients to the cheapest place, to the highest quality place, or to the most expensive place. And then there's another hypothesis, which we mentioned in class, called the medical arms race hypothesis. And that means greater competition among hospitals for physicians can result in redundancy in the overconsumption of medical technologies. This can actually increase costs without improving quality. And what this all means is, in most markets, as technology increases, the costs go down. But what ends up happening in healthcare is, as technology increases, I now have to compete with the other hospital that got the brand new technology. So I also buy the brand new technology. And rather than having centers of excellence where we are differentiated product oligopolies, and we all say, I specialize in this procedure and that's it, what hospitals tend to do is do everything. And they want to be all things to all people. So we're all buying all the latest technology for all the different services. And then we have to find patients to pay for this new technology. So now we begin to induce demand to pay for all of this technology. So only in healthcare, you see advancements in technology actually increase the cost of healthcare. And there's lots of empirical research about the effects of hospital competition on patient outcomes. You can have so many studies that say there's good reasons and there's bad reasons. You have to really get into the research area to kind of break down which arguments are correct and which ones are not. The key here, though, is that technology does not always lower costs in the health economy, and you have to understand the dynamics as to why. Now, for-profit versus nonprofit hospitals. In New York State, hospitals are required by law to be nonprofit. However, across the country, there are such things as for-profit hospitals. And there started to become more for-profit hospitals because they said we need to run this like a business if we're going to survive. Because the way the market is set up, hospitals won't survive. They usually tend to have low margins. A very good margin for a hospital, 1%, 2%. The most profitable hospitals, like a New York Presbyterian, considered like one of the most profitable hospitals, may get to 5%. That's a good year. So you're talking about very small margins, even though they're handling billions and billions of dollars in revenue, but it goes right back out paying for their doctors, their hospital, and the physicians. So majority of the hospitals in America are nonprofit. As of 2009, 75%. However, there's an emerging network of for-profit hospitals, Tenet being the biggest. You can Google them. You can look at their stock ticker. and they own many hospitals around the country, and they're for profit. And the only difference between a for profit and a not profit for a hospital is that they have to do charity care. They have to have a mission and vision that wraps around, that involves taking care of the community. And they have to make sure that they get most of their revenue from their mission and vision. So if they say my mission and vision is providing high quality health, they can't start making revenue out of their urgent care clinic, which is a for-profit entity under a hospital, because then that would be pierce the nonprofit status. They have to continue to make lots of money and revenue through what their mission stated as a nonprofit, which is to render care. And they do have to do charity care as well, meaning that they could have to take care of patients for free who tend to be low income, poor, or just in dire straits. So what's the benefits? Benefits of a nonprofit status is you're exempt from taxes. So if you are a nonprofit hospital, you're not paying taxes. That automatically gives you some favorability. As you know, we just did a corporate tax cut from 35% down to 15%. Nonprofit hospitals weren't paying taxes to start with. It was the for-profit companies that were paying the taxes. And then the other piece is that the people who donate to you receive a tax deduction. And one of the reasons they did that is said, how are we going to ask people to donate to us? And one of the ways they did it through tax policy is say, well, if someone donates $1,000, then that's $1,000 off of their annual income that we won't tax them. So the more you donate, the less taxes you pay. Now, there are downfalls to having a nonprofit status, and the fact that there's law that requires all hospitals to be nonprofit, yet physicians, urgent care clinics, health insurance companies, nursing homes can be for-profit companies, even laboratory services, home health agencies. It's an unfair playing field for hospitals because they have to be nonprofit, but yet they are in an industry where there are for-profits. And some of those stipulations for nonprofits are they cannot sell stock. And this is a big deal because stock is a way that for-profit firms get capital to do different things. That's how they invest in themselves. That's how they raise capital. So the fact that if you cannot sell stock because you're not for-profit, you're nonprofit, it's harder to get funds. So a lot of the things that hospitals have to do in order to get funds to, say, build a new unit is either through philanthropy, fundraising, or it's through debt financing, meaning loans or bonds. But outside of that, they cannot issue shares for people to buy stock and then get their revenue through the shares because they're a nonprofit. The other thing is they cannot distribute profits to owners. Technically, for nonprofits, the public owns a nonprofit because the nonprofit is there for the public. And so if the public owns it, then there's technically no shareholders and there's no owners. It's a public good. So that is why you can't give profits back to owners. And why is that important? Because if you can give profits back to owners, then owners would give more money. So with donations, you give money, but if money is made from the money you gave, you don't get any of it. You'd give it out of the sheer philanthropy aspect or the tax benefit, as we discussed earlier. And then we talked about this a little bit. I mentioned it earlier. There's restrictions into certain charitable activities. So if you are a charity and you are a nonprofit, you're required to do a certain percentage of your work in your mission and vision. So you can't just be a nonprofit in name only. For example, you can't be a hospital and say you're a nonprofit, so you don't pay taxes, but then open a hotel business and make 90% of your revenue through hoteling. That's basically not being a nonprofit. So the government regulates to make sure that at least a large percentage of your revenue is coming through the mission and the vision that you stated in your entity. And that's seen also through the 990 that we discussed before. Now, why do nonprofits exist? There's a number of theories, and these are all important theories to know. I'll go through them and I'll tell you my personal view of the world. So there's an altruistic motive theory for a nonprofit, and this is that some entrepreneurs, and this is big now, not so big back then, but this is big now. Some entrepreneurs prefer altruism over profits. And there's a big move now in social entrepreneurship, which looks at starting businesses to help special causes. You can think of like Tom Toms, the shoes, where every shoe you buy, Tom Toms gives a shoe to a child in a developed nation. And so that's a type of a nonprofit. They're actually for profit, but it would be the same type of deal if another nonprofit was doing the same thing. But it's really around entrepreneurs that want to do something nice versus just make money. And you see a lot of that with the Clinton Foundation, though controversial in some parts, and also the Gates Foundation, where they're spending money, lots of money, looking for nonprofits that are doing good things. Nonprofits also exist to fill the gap where there's government failures. When politics ineffectively can't help, then nonprofits are able to fill that void. And the best way you see this is Red Cross, and you see this with the Boys and Girls Club, and even the YMCA. So, like Red Cross, where FEMA may not have the funds to go into an area and help, Red Cross as a nonprofit enters and helps. And rather than standing up a whole infrastructure, Red Cross is already built to take donations and to send volunteers. Sometimes the government also relies on these institutions. Boys and Girls Club, you're talking about after-school programs. You know, if the town and the city can't pay for after-school programs, you need a nonprofit like YMCA and Boys and Girls Club to intercede and fix a government failure. The fact that the government couldn't pay for after-school programs, mentoring programs, and things like that. Asymmetric information. So because you don't know where your money goes, if a hospital is for-profit and you donate it to a for-profit hospital, people would assume that the money would go right into the CEO's pocket. So the fact that the nonprofit, the hospital is nonprofit, we believe that people feel more inclined to give the money to a nonprofit because they're more trustworthy. And they say asymmetric information because the donor doesn't have as much information as the company. And so if the donor is going to give money, they're most likely going to give money to a nonprofit versus a for-profit. For-profit is trying to make profit, so if they're getting donations, they most likely will just send it to the profit side. Whereas a nonprofit, they don't have profit technically, theoretically, because they're a nonprofit. So they're using as much money as they get to go towards the cause at hand. And then there's skeptical folks who say, listen, man, the only difference between nonprofits and for-profits is the tax shelter. And so they're just for-profits in disguise. And I can understand the argument because there's nonprofits that make hundreds and hundreds of millions of dollars. And so what they do is, while the nonprofit doesn't have profits, what they end up doing is they distribute the high wages to the nonprofit folks, and that's their vehicle of getting profits back to the owners. So while the nonprofit employees aren't the owners, they are the highest ranking folks in the company, and they can get a higher wage as a result. So these are the four different theories of why nonprofits exist. I personally believe nonprofits exist for government failures, where the government can't do something well. Nonprofits step up and get into the community and help out. Now, last but not least, we'll talk about the relationship between hospitals and payers. So prices vary greatly across hospitals. In Bitter Pill, we talked about the charge master, the famous charge master. And why does the charge master exist? So earlier on, we talked about how Medicare and Medicaid has fee schedules, and those fee schedules determine how much is paid for each procedures down to the CPT code. However, there's negotiated rates for private insurance companies, for-profit insurance companies like Empire, Blue Cross Blue Shield, and like United Healthcare. So those are done based on a different fee schedule, and they basically are negotiating rates directly with the insurance company. And then prior to the Affordable Care Act, there was an uninsured population that paid out of pocket. So there was a third mechanism that the hospitals had to come up with to figure out how much they charge. And that's really was charge master. And that's the way they know how to handle self-pay populations. These are people who don't have insurance and are paying out of pocket. And the charge master was really developed to have a price list so that people knew how much things cost, even though insurance companies were paying negotiated rates and Medicare and Medicaid were paying their obviously budgeted rates that are voted upon by the government. So charge masters exist as a way for hospitals to figure out the price of something if someone does not have insurance, and also as a way to figure out if someone is out of network. So they do have insurance, but they're going to a hospital that's out of network, so it's not in their network, and they have to come up with a price. They also use this as well. Now, there's tremendous variability, and people rarely pay the charge master price because of insurance and because of Medicare and Medicaid, and because even if you do get a price, you can usually call the hospital and try to negotiate down the rate. But they do exist. It's where it's the starting point of the cost. And you'll see in Stephen Brill's article, he talks a lot about the charge master and how much money that was being shown in bills for hospital services. But again, the charge masters aren't used as much because of the negotiated rates, but the rates vary between competitors because of the different bargaining power by the hospital or the insurer. So we talked about how hospitals have bargaining power with the HHI index, so they can tell their leverage. And health insurance companies usually tell their leverage by how many members they have. And so, for example, Health First has 1.5 million members. Empire Blue Cross Blue Shield has over 6 million members. So Empire Blue Cross Blue Shield has more members to use as leverage for negotiated rates to get them down, because they're basically saying, I'm buying healthcare services in bulk, so give me a discount. Where Health First, yes, they have 1.5 million members, but they don't have as much leverage as, say, an Empire Blue Cross. That's just as an example. And so you can have the same procedure be different prices based on which insurance company you have. And then you can have the same hospital receive different rates for the same procedure based on the different insurers. It's very complicated. And that's why transparency is so hard in the healthcare space. And then we talked about the people who don't have insurance, the uninsured. And this is the reason why healthcare is so expensive, because we have uninsured populations that are required to get coverage, and that coverage is really spent at the charge master. And people can get into debt for not paying this coverage, healthcare costs, because they don't have insurance to cover it. So we have this law called the Last Resort Law, which mandates hospitals to treat all patients who enter their emergency rooms. This law was done so that people who come in sick aren't just not taken care of because they don't have insurance. And we don't have a constitutional right to health care yet. So one of the ways to get around it is to say, well, we don't have a constitutional right, but if someone comes into the emergency room and they're in really bad shape, you have to at least stabilize them. So if someone lacks the resources and the insurance to pay for care, it becomes uncompensated care. And there's a pool of money that the government does to pay for uncompensated care. However, it's nowhere near the amount of money that the true cost is. It might pay 3, 4, 5 cents on a dollar for uncompensated care. You don't get the true cost of the expenses from the uncompensated care pool. There's also something called DSH, disproportionate share of hospital. And there's actually money that's set aside for hospitals that get a disproportionate share of people who are low income, Medicaid and Medicare low income folks. And what they're trying to do is say it's unfair for those hospitals not to get some revenue. So they take revenue from some hospitals and give it to other hospitals who handle those low income, poor populations. But ultimately, whether the member can pay or not, the payment has to happen and it gets into the system. So if a hospital has a lot of uncompensated care, what they'll end up doing is cost shifting the uncompensated care to other contracts, like their commercial contracts. And that's why when we showed the slide of healthcare dollars, public and private, you saw that the U.S. private cost was so high because whatever is not being paid on the public side gets pushed off to the private side. And that's where you see that the unpaid hospital care is done through cost shifting or cross subsidization. Richer patients pay for the poor patients. And in the U.S., reimbursement rates are much higher for private insurers, again, than for Medicaid and Medicare. And this is going to continue to happen. This is like you are a hotel and someone has a Groupon visit. Someone pays the price that you had on the website a week ago when prices were low, and someone walks in and says, I need a room tonight. The person who has a Groupon ticket might have the cheapest hotel room. The person who booked a week ago when there wasn't as much demand might have the second cheapest, and then the person who comes in tonight, you can charge them as much as you want because they need a room. And so that's the same type of leverage that happens in the healthcare space. So with that, we end the presentation for hospitals. You'll see in the homework that we get into more details around hospitals. And the big takeaways are the fact that hospitals have a big barrier to entry. Many of them were created by the Hill-Burton Act. You have to know that. And that's government intervening to try to fix an issue with healthcare. And so you have a lot of hospitals that come into play. You have to understand the dynamics between how hospitals and physicians operate. Do they own the staff or do they not own the staff? And what does that mean for the care that they render? And then most hospitals are nonprofit. What are the pros and cons around a hospital being for-profit or nonprofit? That's very important. And then last but not least, healthcare gets paid whether it's uncompensated by the member or not. And that's important to know.